Alrighty, this is the continuation of Chapter 18, Transport and Positioning. Um, so we left off, we were talking about kind of some of the duties of the surgical tech and why we need to know kind of positioning so that we can help put these patients in these positions and know what to protect, things like that. And then we're going to go into, the operating room table itself. You guys have seen a lot of this already. It's got the pads, the remotes, they're electric, the headboards, the footboards, kidney rest that goes up. You can the perineal cutout for lithotomy, GYN procedures, urology procedures. Um, Another thing is operating room tables have weight limits. Each table is different. They do now have bariatric beds to stand the heavier patients and things. It used to be that we'd have to put two beds side by side, but to distribute the weight, because I think early on the max weight I think was like 350 to 500 pounds per patient, but we know that that we can have patients that get bigger than that, so they design bigger stuff now. You can take the head section off and move it down to the feet. That's what we do for lithotomy. That way the patient's feet don't hang off the end of the bed while we're putting them initially to sleep in supine. The pads, right? And I'll show you guys this too in lab. I thought I mentioned this to you guys, but it might have been the last class. There's a space in between the pads and the actual bottom of the bed, so you can fit an X-ray cassette down it. You can use the remote or the hand control unit, or like you saw the manual one, the hydraulic lift, where you're pumping it. The base is the part that's on the floor, where all your wheels are at, or those casters is what they call them. And then you have that side rail thing where you can hook your attachments and equipment and things like the positioning equipment and stuff too. So some attachments that go on, arm boards, the toboggan or sled. It's something that when you tuck the arms by the patient's sides, it kind of looks just like a sled. It's curved right up on the front, kind of protecting, and that would cover their arms so that, when we're standing up next to the patient, we're not like leaning and pinching and putting pressure on them and things like that. We talked about the shoulder braces for putting patients in reverse Trendelenburg, going head down, right? So those braces keep them from sliding off the table. The patient in the stirrups, headrests, you've seen those. There are also other kinds of headrests, the Mayfield headrest for one, or the horseshoe headrest. It looks just like a horseshoe, just a little small padded thing, typically used for craniotomies. But we can have frames, things that we hook up to the bed to hold patients in certain positions, the footboard when we're going in reverse Trendelenburg. And then we need to pad, those bony prominences, trying to prevent any kind of decubitus ulcers or deep tissue injury. And then also, we don't want these patients sliding on the bed at all, because we can cause what's called a shearing injury. That's where, like, if you were on your back and you were sliding down towards your feet, the skin on your back would stay still, but the rest of your body would slide. It would basically kind of just shear. It's like shearing sheep. If you think about it, you're taking off long strips of tissue and things like that would be kind of tearing away from one another. Some things we definitely want to avoid is any kind of, like nerve injuries, things like that. We never extend the patient's arm on the arm board past 90 degrees with them laying down, because we're going to cause injury to the brachial plexus and the nerve bundle of nerves in the shoulder that come down and innervate our whole arm. We never want to put anything in hyperextension, kind of overextending it past its 90, right? That's that I was talking about there with the shoulder on the arm board, right? Hyperflexion. Now we're putting something in over, so you like flexing the arm, but now you're making it kind of crush down. You're putting pressure and everything on that joint. Sometimes we'll also put patients in what's called traction. Usually when they have a fracture of a bone or something like that, we're trying to get that bone back in alignment by pulling on the outside of the skin and the tissues. Usually you'll wrap like a boot around a foot and pull on the foot. What you're trying to do is pull on all that bone and then get the fracture to kind of line back up. But you can end up with injuries like that. You can cause some kind of shearing and things like that if you don't put those traction devices on correctly. Um, that can lead to necrosis, right? Especially that pressure, things like that. It's pinching off, uh, blood vessels and things like that. Things that can get those oxygen and nutrients to those tissues. And then ischemia is the cutting off of that blood, right? Necrosis is actual, dead tissue. And ischemia means that it's not getting any blood flow, which means it's not receiving oxygen and nutrients for the tissue. A lot of common locations: ulnar nerve in your elbow here. That's why we pad. Right? Perineal, tibial nerves on the tibia, usually from either in position. The tibia, if the lateral part or the outside part of the tibia is resting up against the hard plastic part of the stirrup for a long time, so we sometimes will pad that area too. Brachial plexus up in the upper shoulder, and then the lower back, the lumbar sacral nerve root. The ulnar nerve is usually the most common nerve injured because of positioning. We end up stretching them too far, or if we bring the arm over, we end up with we have it hyperflexed or something like that. Usually it's just kind of a negligence. You're not paying attention. You're in a hurry. Prevention, right? Table padding, linens. Linens we tend to try to avoid, but to their cost effectiveness and reusability kind of thing. It's not outlawed that you only use like gel pads and things like that. We can use linen. We just need to make sure we don't have any like wrinkles or like knots and something, or something that kind of hard and dense that the patient's going to be resting on. We try to move things according to its range of motion. Right? If a patient says, I can't move my neck really well, or I can't move my arm, this is about as far as I can go, then that's, we kind of curtail our positioning to what's most comfortable for the patient. There's that shear injury, right? Usually it's in Trendelenburg and reverse Trendelenburg, because that's the times you're going to get that patient sliding on the table. Then with these pressure ulcers, usually they're defined by the stage. Pressure ulcers happen from the inside out. So what happens is the bone that's putting pressure starts killing the tissue that it's immediately touching first, and then that spreads to the outside, which is why you have such a big like crater and things like that, is because long before you saw like any kind of redness or swelling or anything like that, any kind of signs of a pressure ulcer forming, it was already forming way deep. So, and then compartment syndrome, that's when the tissues between the muscle and the fascia start swelling. Sometimes it's caused by, laying on like your arm or your leg or something like that. You cause it to fall asleep, but not feeling it in time to get, to take that pressure off. And it can also happen in the abdominal muscles. It's pretty much wherever muscle and fascia are together, and muscle and fascia are together pretty much all over your body, wherever you have like skeletal muscle. So once that starts swelling, there's nothing to relieve that pressure. it's going to start killing the muscle and the tissues and everything around it because it's putting pressure on the blood vessels. So the only surgical intervention is a fasciotomy. So you actually have to go in and cut the skin, cut the fascia loose so that it has that room to swell. And we leave those incisions open for a few days. We'll send those patients over to the ICU. We'll put like a wound vac dressing over the top of it just to keep it, from getting like infection and things like that. But it gives it that ability to kind of swell and do its thing until they can get things to kind of calm down. So stage 1, reddening. You start to see some reddening just below like a bony prominence. Stage 2, you're getting some little bit of skin loss, maybe a small ulcer starts to develop. It's a little shallow. And then you got the big crater, full thickness tissue, right? Partial thickness being just like the epidermis layer, maybe slightly into the dermis. Full thickness, now you've taken both epidermis and dermis. And then in stage 4, now that ulcer goes all the way down to the muscle and the bone. That's something we just have to be aware of and watch for. You make sure we're padding those areas. That if a patient has any, one in any one of these stages already, that we're not doing something to kind of further that along. So that range of motion, you don't want like legs and arms dropping over the side of the table. Everything's always must be secure because you could be damaging, nerves or tissues and things like that with it hanging off to the side. It's not a natural, comfortable thing for the body. Can lead to blood clots, like a thromboembolus. Remember, a thrombus is a blood clot that is stationary. It is just sitting in the vascular system waiting to go somewhere. And then embolus is that clot now on the move. So it's headed to like your lung or your heart. And if it arrives at either one of those, it could potentially kill the patient. Sometimes we'll put on anti-embolism stockings, known as TED hose. They're like pantyhose, real tight stocking they put on over the leg. That's to help keep that compression and keep that blood flowing through the veins. And then you have the SCDs, or sequential compression devices. These are those leg massagers. At each side it'll pump, it'll kind of fill with air slowly and kind of pump that fluid back through the veins. And then as one side lets down, the other side is pumping up. So it's kind of like a massager, is what a lot of patients describe it as. Patient could have a respiratory, issue related to positioning, right? If we're prone, we want to make sure like breasts and any kind of like extra tissue and things like that isn't up here in the neck pushing and causing an issue. We want to make sure that's all stays down. Falls, not common at all. People are pretty adamant and vigilant in the operating room as far as, when we have our patients and we're positioning and being careful, communicating and everything like that, which is why it can be kind of devastating if a patient does fall, because it is pretty rare for it to happen. So we have a lot of things in position and in place to prevent these falls. But to deal with them, it's like a risk management kind of thing. There's going to be paperwork that has to be filled out, talking about the incident and who was involved and how, they come and look at our processes and make sure that we're doing the right thing, and then all that kind of stuff. So, but when positioning the pregnant patient, a pregnant patient cannot be laid supine, completely supine, because the baby can come over and put pressure on the vena cava. So we need to take a wedge or a pillow or something and put it underneath the patient's right side to get them up and tilted so that the baby doesn't lay or put pressure on the vena cava, and then that diminishes the return for mom, which then will in turn affect the baby because now the baby's not getting as much blood because mom's not getting as much back to her heart. Can cause a serious drop in blood pressure and compromise both mom and baby. So we always put a wedge underneath that right side to tilt the patient just slightly up onto the left. We're not going like full lateral, but just kind of a bump underneath that side. So some safety precautions in supine, right? We talked about this in lab, right? You want to keep that cervical spine and head in alignment, right? In a nice neutral alignment. You don't want to be tilting them or tweaking or anything like that. Like anyone who's ever woke up, with like kind of a crick in your neck, it's not a fun time. Padding that ulnar nerve. You're protecting that brachial plexus by not hyperextending the shoulder. You're preventing those decubitus ulcers by padding under the heels, under the back of the head, under the elbows, things like that. You're protecting that popliteal fossa, which is behind your knee. You might put a pillow under there, partly to relieve, pressure off the lower back, but it also protects that area from damage or something happening to the popliteal artery. You want the patient's feet separated, which means they can't cross them. So like they don't want your feet crossed because that's pressure that's being placed behind on that Achilles tendon and the nerves that are back there. And when you go to sleep through anesthesia, if they come over and then uncross your legs after that, your body and your nerves don't know that it's been moved. It's still sending the signal to your brain, so it thinks something's wrong and it acts accordingly. And so it may shut down when you end up with that foot drop on just one foot. You never use knee crutches. I don't know what a knee crutch is. But yeah, making sure that their legs aren't crossed. Trendelenburg, right? Shoulder braces, protecting that plexus, still padding those pony prominences, right? It's given us that better access to organs within like the pelvis, the lower abdomen, things like that. Some risks would be, some shear injury to the patient, if they were sliding, things like that. Reverse Trendelenburg, right? Foot down, footboard, right? You might use a magnet pad. It's a sterile pad that we have. It's got a bunch of magnets on it. We can actually stick our instruments to it so that they don't slide off the sterile field. But we're still padding those bony prominences. We could still have a chance for that shearing injury because we could slide, right? But that's what that footboard's for. And now we're accessing those organs of the upper abdominal cavity and that area. Lithotomy, remember, it's just a variation of supine. It takes two people to put the legs in the stirrups and to bring them out. So it has to be both legs at the same time because of blood pressure, right? And trying to protect that perineal nerve. Usually before we put the patient to sleep, or what's called induction, we're going to make sure that patient's bottom is right there at the edge of the perineal cutout, right? Remember the anesthesia's got the time for the count and all that. So both legs up together, nice, even, slow, same time. Protecting that perineal nerve, slow manipulation for blood pressure issues. And obese patients may have kind of a hypovolemic when we're bringing the legs back down. because all of their blood and everything has been up here in the upper torso with the legs up in the stirrups, because kind of gravity has kept a lot of it up there, right? Well, then when you bring those legs down, even bring them down slowly, because there's so much fluid that has to shift, then the upper torso, you being used to having so much for a few hours, now has less, and it's got to kind of catch back up and rebalance. So you may see some blood pressure changes and anesthesia kind of freak out a little bit, but just know that there is an explanation behind it. That it may not be an emergency situation. We may just need to wait about a minute or so for the patient's own body to stabilize. So for orthopedics, we have certain tables called the fracture tables. You must have 4 people to place people on these tables because they are specifically designed. It's like one piece of it is missing. Usually the foot piece is taken off, and we'll put both feet in like these traction boots, they call them, and then they can actually dial up and pull, stretch, and pull on the patient, putting them in traction. It allows us to get all the way around these limbs to bring in the C-arm, the X-ray machines, to see the bone we're working on and things like that. We'll have what's called, affectionately in the operating room, it's called the pleasure post. For these fracture tables, it's a padded post that goes right in between the patient's legs. And it's basically the only thing that keeps them from rolling off the table once we get them fully into position. So, but we're still padding all those bony prominences. We're still, even when we put the feet in the boots, they get wrapped in cast padding first, and then they get put into like this padded boot, and then they get put into the hard plastic boot. So we make sure that those patients are padded, that things aren't going to get injured. Sitting, Fowlers, right? Facial, cranial, reconstructive breast surgeries. Like I said here, the frequency of this position has really declined. It's not, you're not doing an entire procedure in this position unless you're doing shoulder arthroscopy. Is mainly the one that you're going to see it for now. Lateral, right? Thoracic, kidney surgeries, intubation, extubation, we do it in supine, and then we move the patient. It's not 3 people, it is 4 people, because you need one on each side, one on the head, and one at the foot. It is 4 people. And we work together, communication, right? We're going up on 3 and then turn. But, we did this one in lab. We practiced this one. Remember that bottom arm is out on the arm board, the upper arm on an overhead arm board or on a pillow over the top of the patient. You got that axillary roll just below the axilla or the armpit. Pillow between the lower legs, and it's the leg that's touching the table that gets fully flexed, not just semi-flexed. Because semi-flexed is kind of like just like a barely. Fully flexed, like you fully flex it. You bend that knee to keep them from being able to roll. Prone position, right? Face down. Right? You got jackknife or Kraske. You can, for spinal surgeries, you can put them on like the Wilson frame, things like this. 4 to 6 people to move, depending on how big the patient is, things like that, because we have to fully flip them over and then kind of position them into the equipment that's holding them there. But definitely we got to pad the face. Still the elbows, if the arms are out up on the arm board above them in kind of a Superman position. We got to pad the knees. We got to make sure that the toes aren't down and digging into something. There's that jackknife. Right? Usually those anal rectal procedures, hemorrhoids, pilonidal cysts, things like that. But we're still padding those areas. We're protecting, the female breast, making sure they stay down, male genitalia, not everything's all like bunched up or pinched up in between the legs. Still protecting that brachial because the arms are above. We don't want it to extend too far one way or another when we're bringing them through its normal range of motion onto its pads, things like that. Cornea, you can end up with corneal abrasions in this position as well because your head is down. You're getting a lot of pressure put and a lot of blood flow is going to the head, kind of making the eyes kind of bulge out just a little bit. It's not like super, uh, but it can cause those corneas and maybe cause the eyes to open a little bit and can cause maybe some scratches and things like that on the cornea. So things to just keep in mind on prone position. And that leads us to questions. No questions? Excellent. Then we will move into chapter 19, which is prepping and draping the patient. Uh, this is why we're doing our prepping. It's the same reason we do the scrub for ourselves. We're trying to get rid of transient flora and reduce the resident flora to an absolute minimum. Right, we'll talk about this more about flora and microbes and things like that when we get into chapter 8. Patient hygiene. Prior to surgery, it's typical that the surgeons will give them like orders to take, chlorhexidine gluconate shower with an antiseptic soap or antimicrobial soap or bath to clean their skin off, just to kind of make it resistant against collecting any more transient microbes and things like that before they get to the hospital on the day of their surgery. If we're doing something on the hair or scalp, then they'll have you wash your hair with the chlorhexidine and not put any like gel or hairspray and stuff like that in your hair because that's going to attract microbes. The reasons we do put in a catheter on patients. Now, this is all part of prepping the patient for surgery, right? Getting them ready is bladder protection, right? We do that by keeping it empty and keeping it out of the way. Right? And then sometimes we need, and that's part of that bladder protection, decompressing it. Also, we're working that area and we need it to be small so we can see the other structures that are around it, right? We always monitor how much urine has been put out. So if it's in the bag, what you'll see is the nurse will save the bottle of saline that she used to pour up onto your field. And then she will empty the Foley bag into the bottle of saline, and then she can report to anesthesia how much urine they got out. What anesthesia is looking to see is that the urine output closely matches the IV input. It should be very close to the same. If it's not, if you have very little urine output and you had a lot of IV, either you were severely dehydrated or that fluid is going into some other space in the body and we've got maybe something else that's going on. It could be a clue that there's something else going on with this patient and we need to do something to help them. Do you guys know about putting in the Foley? We already did this, right? You need the kit, the sponges, the solution, your lube, your sterile gloves, that 10 cc syringe that had water in it, right? You need the drape, you need the little forceps that picks up the little cotton balls, right? That got the betadine on it. And then you need some kind of drainage bag that's hooked up to your Foley. Pretty easy. The only one that doesn't need a bag is the straight cath, right? Because that one's just going to go in, drain, and come right out. We know all these steps, right? How we go through putting in the catheter for the female, and then how we That's if the patient's laying lateral here in E, and how we would kind of secure this to the bed. Right, you want to leave some slack in it, and then you notice that there's some slack. It's not pulled tight coming out of the urethra and then taped down. There's some slack in it so that it's not doesn't have that tug effect to it. Then for the males, right, same thing. Notice that there's some slack in this line, so you don't have the tug. And there's the Foley inside the patient. See if I can't zoom in. So this is the balloon, and that's how it stays in. And then you've got the openings here, so as the urine collects and gets up to the level of the hole, it goes down into the tube and then goes to the bag. Patient safety, we need to make sure that we're not giving the patient a UTI, a urinary tract infection. Right? And the way we do that is making sure that we're always wiping front to back. Right? That if the patient happens to be pregnant and you give them a UTI, you can cause death of the fetus, because now that sepsis in mom spreads to the baby. And in trauma, sometimes, if there's been trauma to that area or something like that, a surgeon or a urologist, you would have to call them to get the catheter in, or if there's like a stricture, which means like a closing off of the urethra. If you're just trying to get it in and you see a little bit of blood come back in the tubing into the drainage bag, then it's like, okay, obviously, you don't want to cause any more harm and shove it through and make like a false hole or something like that. So it's best to call a urologist at that point. So what is our primary defense against infections? Intact skin. It has to be intact, right? But it's got microbes that live on it, like Staphylococcus aureus is the #1 cause of surgical site infections because it's resident flora. It's already living on the skin, so you can see how it could, be #1. It was already there. It was like the only one there waiting for a break in skin to happen. Right? Hair removal, right? Usually requires a physician's order. They tend to be standing orders if you're doing some kind of abdominal surgery, and you take the blankets and the gown off the patient after they've gone to sleep to get them ready, and you see they're just hairy. It's kind of understood. Well, we got to go in there. We need to shave that hair. You don't have to call the doctor and be like, hey, he's all hairy on his abdomen. Do you want me to shave it? It's kind of understood. But he does have to write an order in the chart. We try to complete it as close as possible to the start of the procedure. Typically, it is supposed to be done outside of the operating room. It's supposed to be done over in pre-op so that we don't have all that little hairs and all that loose stuff in the OR. But a lot of the pre-op nurses, they don't want to do it. Patients don't like, being shaved. They're awake and stuff like that. It's awkward. So we typically do it in the operating room after they've gone to sleep. We will use electric clippers. That's what you're going to see most often. We don't use razors anymore because it causes too many micro abrasions in the skin, especially around the incision site. That's going to lead to a higher incidences of infection. I don't see it very often, but you can use a depilatory cream. A depilatory cream is Nair. Interesting story once when I turned 16, I had my mom had let me have some guys over, kind of a party thing. They all spend the night. At the time my mom was seeing someone, and his son was kind of a doofus. We didn't like him much. So when he fell asleep, we took some Nair on a Q-tip and just kind of dotted around on his eyebrow. Yeah, it was pretty. It was pretty funny. It was pretty funny, and it also taught me. Uh, I mean, not that this didn't teach me eyebrows don't really grow back, but uh, that really showed me that you don't really want to shave or mess with eyebrows because they really do not come back. That's why we never shave eyebrows. Uh, they might come back, they might not come back. It's kind of a crapshoot. If they come back, you're like, okay, whew, it's lucky. If they don't, it's like, oh no. Um, but we use single-use clipper heads where the handle is non-disposable, but the blades are disposable. You hook one on, you shave that patient, and when you're done, that one goes into the sharps bin. You wipe down the handle and put it back on the charger. Skin markings. This is something that the surgeon has to do. We talked about this in transport and transfer when the surgeon comes over and talked about like marking, like what it was for the eye and things like that. But they have to use the blue or purple skin marker, and they have to mark their initials on or near, very near the surgical site to prevent wrong site surgeries and wrong person surgeries. The Genitin Violet is the ink that is inside your skin marker. It is its natural properties are antiseptic, so that's why that's what you're going to see throughout every OR you will probably ever go to. Uh, you can't use like regular ink, like a regular pen or anything like that, because those can get washed off. The skin marker can get washed off too with like the alcohol-based preps, but then once you're prepping that area, then we know we're working on that area because that's what just got prepped, so it's okay. Um, some approved preps that we use: alcohol, right? It's quick. There's a lot around, right? But it's very dangerous in terms of its flammability and its like volatility. It can flare and get trapped in pockets and things like that underneath the drape, which is why we need to let it dry completely. But we can never use any alcohol-based preps on a mucosal membrane because it'll dry them out real fast and it'll kind of kill that tissue. So we can't use it anywhere like near the mouth, the vagina, the urethra, anus. All of those areas have to be prepped with the betadine. Chlorhexidine gluconate. This is what you see in the scrub brushes. This is what we scrub ourselves with. It's a much gentler detergent. The iodophore will kind of start to darken your skin and the hairs on your arms and stuff over time. But iodophore is a great. Iodophore is like the betadines, iodines. Anything that's got the iodine in it is considered an iodophore. You can't let that one pool though, the iodophore ones, because that's where you're going to get like your chemical burns and stuff like that. But it has residual activity after it dries. It is constant, keeps kind of killing microbes and preventing the growth of microbes and things like that. So it's why it was first used because of those properties to it. And there's different preparations available, different strengths. Like you've got 10%, 5%. It depends on where you're using it. For the iodophores, if you're using it on the eye, you need at least a 5% dilute form of it because too much of it's going to start to destroy the eye tissues and the conjunctiva and things like that. And also, you can never, ever, 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 ever get iodine or betadine in the ear. It is toxic to the eardrum. It will destroy and kill your eardrum. So no betadine ever into the ear. Usually if we're prepping the face or something like that with betadine, we'll put cotton balls or something like that in the ear to prevent just even runoff of betadine going into the ear. Triclosan, the hexachlorophene, the parachlorometazolinol. These are all like, they have their own bacterial or antibacterial properties and things like that. But these are going to be used for mainly those patients who they have like an allergy to the other ones. Like they can't have the chlorhexidine, they can't have the betadine, and we're working on like a mucosal membrane or something like that, so we can't use the alcohol. So then we have other alternatives to turn to. You don't see these used as often. You may use like triclosan. You can also use it as a surgical scrub if you're allergic to the iodine, chlorhexidine, the other options and things like that. So I've seen some surgeons use the triclosan over the years. Skin prep, things that you're going to need, and usually it's all in that kit, right? You guys have seen the kit. You've got your gloves inside there, the blue towels for drying, right? And then you've got the white towels for preventing that pooling underneath them, right? To kind of tuck underneath their sides. You've got your little prep sponges. Shouldn't need any instruments. You've got your antiseptic solutions. You shouldn't need any sterile. Well, we'll talk about the sterile water. If you're using chlorhexidine gluconate, you pour a little bit of that in and then you dilute it with water when you go to prep with it. And then you got your cotton tip applicators, right, for cleaning out that nasty, nasty belly button. You can do multiple areas at the same time. You're just going to need more than one kit, right? You never ever use a counted sponge to do a prep. And then try to respect the patient's privacy as much as possible, right? You don't want to uncover areas that you don't need to uncover. So if we're going, say nipple line, I mean, this is what you're going to see most often out there, even though the book says we're supposed to go nipple line to hips, so nips to hips. What you'll see is they'll take the patient's gown and just, they won't expose the breasts or anything like that. They'll leave it right at the bottom of the breast and they'll just prep up to where they put that gown. They won't go all the way up to the nipple line because, I mean, we're a little past the xiphoid process. If we're going any higher than that, we're entering the thoracic cavity if we're doing an abdominal procedure. So, and we shouldn't really be entering the thoracic cavity. You gather those supplies, put them on the table. Usually it's just that kit, right? You're going to open it, do an aseptic technique. We did this in lab just this last week. And then you're making sure that you're going to be prepping the right area. Just look at the chart again one more time and make sure, okay, yep, this is what we're doing. Boom. And then perform your prep, right? So your checklist is prepare the patient first, right? So you need to uncover the areas that we need to prep and get the patient all situated and make sure that they're positioned right and all that stuff, right? So that's preparing the patient. And then you prepare your supplies. So that's getting everything opened. Boom, get your gloves out. Now you're preparing yourself, getting dressed, organizing your little kit. And then you can either do the 2 or the single stage prep. The 2 is the betadine and betadine, the wet, dry, and scrub and paint, right? And the single stage one would be your alcohol-based preps. That would be, like the chloro prep, more of your alcohol-based, where you're waiting those 3 minutes for them to dry. Some patient safety considerations when dealing with prepping is allergies, definitely. It's a big one. So you want to verify the allergies. You want to make sure that you don't allow any of those solutions to pool under the patient or anything like that. That can lead to those chemical burns. That we're allowing the alcohol base to completely dry or giving it that time to dry so that we can minimize fire risk. And then we need to make sure, sometimes you'll see that to be nice to patients, right? We know the patient's going to be awake for this procedure. We'll take those prep solutions and we'll put them in the like blanket warmer to kind of warm them up, so it's not this cold liquid that's touching them. Well, sometimes they get left in a little too long. They're a lot hotter than you think, so you can cause like a burn on patients. We talked about the eyes, right? You need to dilute the eyes if you're using betadine. You typically don't use any kind of alcohol-based solutions and preps in and around the face. There's just too many mucosal membranes and things like that that can get damaged and stuff. So they typically don't do it. You'll see like the chlorhexidine. They'll even use Johnson's baby shampoo. Really, because it's nice and gentle, no tears, right? You can get it in the eyes and not be a problem. And then, like I said, if you're doing betadine, the ears get plugged. You never get betadine down the ear canal. If you're prepping like the eyes, your borders are like the hairline and like all of the forehead, and then down to just below the nose, and then to the sides. It's just before the ears on either side. So you're this whole area here, kind of a big masked area. If doing the ears, it's usually all the way around the ears. It comes out to like just past the corner of the eye here in the front, and down up along the neck, just where it meets the shoulder, and then up along the back and up to the top of the head of that ear. So you're prepping this whole area. And then when you drape, you only end up leaving just a small area exposed. When prepping the face, you prep the whole face. It's like doing breast surgeries where we will prep and drape both breasts into the field so that we can compare. It's the same thing for the face. We need the symmetry. If you're doing any kind of reconstructive or facial fractures or otoplasties or blepharoplasties, things like that, you want to make sure that both sides look the same when you're done. And then for the neck, if you're doing surgery of the neck, it's usually just above the chin and around the jaw line, the lower jaw line here, and then down to the nipple line of the chest, and then bedside to include the shoulders here. So it's a big prep area because you're working right here in the neck. Breast and thorax, it depends on the breast. If you're just doing like a lumpectomy, you may just prep out just that one breast because you're just doing a small lumpectomy like breast biopsy, so you don't really need to compare it to the other side kind of thing. If you're doing like a mastectomy, axillary node dissections, things like that, you're doing like the whole chest up to the chin. So you're going to include the neck because you're going to include the shoulder, and you can either do the entirety of the arm or you can go down to the elbow, but you need to drape off, and cover over the part of the arm that you didn't drape off because they need to be able to get into the axilla. So the patient's going to be kind of positioned with an arm out. And then when you're doing, so you get all of that whole area and then all the way down to the bedside and the axilla and then to the iliac crest on that side and then back up so that you've covered all of that. Arm and hand, and same thing with like the foot and stuff. You're doing all the fingers and toes all the way up the arm. If you're just going to be working on the hand, sometimes they'll stop at the elbow. And then when you put your stockinette in, that's where you'll stop. And when you put your extremity sheet over the top, you don't go beyond the edge of the stockinette. But if it's a whole arm, then it's all the way up the shoulder, like the middle of the back, this to the middle of the chest and over. So it's this whole arm and the abdomen or the axilla in with it. Abdomen we did in lab, right? Nips to hips, bedside to bedside. Oh, look at that. I just went through them. So there's your neck, right? Flank and back, right? vagina. All of these are in your chapter. You can kind of look through them. I know that your workbook has you like doing some coloring on your first few questions of there and things like that. So just kind of look to see, the borders, because you're going to see that we're only going to be working in one area. We're going to make like an incision in one spot, but we're going to make this huge uh, area of prep. And that's to just be absolutely sure we're not going to cause an infection or spread microbes or anything like that. Um, so the usually when you're prepping the leg, you're going to prep the foot as well. The foot and the leg will typically go um, together. The only times I've seen them not want to prep the foot in is usually like vascular surgeons, because they think that the foot is dirty. They don't want it spread to and they're doing like a fem-pop bypass or something like that, and you need that whole leg draped out. But they don't prep the foot. They just put a clear bag over the top of it, a sterile bag. The hip, that's that circumferential. I was talking to you guys about this, and the best way, if you're the one that has to help hold for it, is that you're going to take those toes and actually physically turn the ankle and turn the foot so that the toes are pointed straight up at the ceiling, because that'll lock that knee for you and keep it stabilized, and then you can hold that leg with one hand. Uh, Possible traumas from skin prep. If a patient has had some kind of cut or damage or something like that to the skin or everything, when you're doing your prep, you can actually start kind of debriding and causing some bleeding to stir up and things like that, because you are rubbing that sponge over that site. It's kind of why one of the other inventions, or one of the other reasons behind that gel prep, is because then you can just take that gel and kind of squirt it on it and then lightly smear it across, and you've accomplished the same thing, and you're not going to stir up that bleeding and potentially cause a lot of debridement and stuff like that. Autograft. This is if a patient, if you're taking some tissue from a patient that you're going to move and use as a graft somewhere else within that same patient. Auto meaning it came from self, right? You need some area on a table to prepare that graft. Maybe put some stitches in it, or unfreeze it, because it was in the teep dish, or an autograft wouldn't be, but like an allograft was in the tissue freezer in the back. You brought it in, now you got to defrost it and prepare it to use for surgery. And an example would be in cardiovascular surgery during what's called a CABG, coronary artery bypass. They take the patient's own saphenous vein from their leg, and that's what they use as the new vein that bypasses one part of a coronary artery to another part, to bypass the obstruction or the plaque that's blocking that coronary artery. Draping. We'll do some draping in the lab. We've got to before we can actually start our surgical procedures, right? So I'm going to walk you guys through some of this, show you the different drapings for some of the different positions, things like that. Part of the understanding is that you got to really be wary of your surroundings, because you got to understand that you are the one who are sterile, and the drapes and stuff that you are holding are sterile, and they're sterile in certain areas of that, where you're going to ultimately end up, like when you open everything up, these are the areas that are supposed to be sterile. And you've got to be careful as to not contaminate you or the drapes while you're putting these on to the patient. So, but we'll go through it. That's that maintaining that aseptic technique. There's all kinds of different sizes and shapes of drapes, some with holes, some without holes. They all have to be properly orientated. And you'll see it and I'll show you on the drapes too, where it gives you like a little picture of a guy, and you just got to match that up to what the patient's doing on the table. Where's the head at? Where's the foot at? Okay, this is where they lay this, and then you can start opening it up so you get the proper coverage of everything. Some of the stuff, most of the stuff that you're going to find out there is going to be non-woven. Woven materials are like your linens and things like that. We typically don't use that for draping. It's going to be this non-woven, paper type stuff that at the end of the procedure you're just going to ball up and throw in the trash. Your incise drapes, these are kind of these plastic drapes that have sticky on one part of it somewhere. There's like your 1010s, 1015 drapes. These are all like a clear plastic drape, IOBAN, and I'll show you some of these in lab. But these are things that we can use as sticky to cover over the top of stuff, and then now it's really stuck down to it, and it's not going to move and shift on us and things like that. It's one of the big things about the drape is once the drape is in position, you cannot move it because now you're dragging stuff from one area that was not sterile up to an area that is sterile and stuff like that. So once drapes are placed, they are not moved unless they are being removed. You can use a half sheet, 3/4 sheet, cover sheet. This is just basically like a sterile. It's not a blanket because it's not like linen. It's just like a sterile cover, just like a giant sheet. I know I keep using the words that are up there, but that's exactly what it is. And when you see it in lab, you're like, oh, okay, I see. We can use towels. Fenestrated drape. Fenestrated just means that it has a hole. That the drape has a hole in it somewhere. It could be a square hole. It could be a round hole. It's just it has a hole somewhere in the drape. Those incise drapes, those plastic drapes with the sticky to them, and then a top drape or a procedure sheet is kind of the same as a half sheet or 3/4 sheet. It just may be more rectangular or something like that, where it's longer than it is wide or something like that. But you'll see all this stuff. One of the things to be aware of is strike through contamination with your drapes. That's when the drape gets wet, and then now it soaks through, and microbes on the the unsterile side of the drape. So the side of the drape that would be touching the actual patient, the patient's like right underneath it. Now microbes from there can pass through the wetness of the water and go from one side of the drape now to the other side of the drape. So that's that strike through contamination. You want to handle your drapes with as little movement as possible, right? It's like we were talking about doing your setups. If you're touching something, take it, put it where it goes. Don't need to touch it again, right? You yourself don't want the drape to touch like the patient or the a non-sterile surface or anything before you're actually putting that drape in place for draping the patient. Like I said, you're not going to shift or move around the drape once it's there. If you are going to be securing something to the drape, you want to use something that's non-penetrating. It's not going to put a hole in that drape. You put a hole in the drape, and now that's another way that microbes can get onto the sterile part. You're passing them correctly, orientated right. And I'll show you this on them. But there's a little picture of a guy, and you match head towards patient's head, foot towards patient's foot. And then anything that's going to fall below the horizontal top of that table, or exactly where that patient is, right? The horizontal part where the patient's at. Anything that goes below that is not sterile. So if you see something starting to fall and you try to catch it, but half of it's below the horizontal part, you just have to let go and let it fall. Typically, if you see something falling, you're just going to let it go, because trying to catch it most often is going to cause more problems than just getting a new one from the thing that fell. Your edges, a lot like when you're doing your open and gloving. Remember, you have that 1-inch border around the whole thing. It's the same thing. So once you place a drape, your edges are done. You never reach over a sterile prep field, which means when we're squaring off the patient with the towels, you have to walk around the bed to place the last one. And you're never handing them to the surgeon over the patient. Like they're not going to stand on one side of the bed and be like, okay, and take them from you. You have to be on the same side. You want to try and use impervious drapes. Impervious means they're like plastic, where fluid can't get through them or things can't get through, right? That's going to help you avoid that strike through. You have certain drapes that have like fluid collection pouches and things like that. If you're doing like arthroscopies or cystoscopies, hysteroscopies, you're going to have like this kind of big bag. And down at the bottom of that bag, there's a spout where you can hook suction to. So then that fluid can fall into those bags and not all over the floor and on our feet and stuff like that. You also have drapes that have aluminum coating on them for laser procedures. So it can kind of dull the matting of the aluminum coating on those drapes is dull enough that it absorbs the laser beam rather than reflect it and shoot it all around the room. But sometimes patients can get put in kind of some strange positions. It's not something that's exactly like lateral or Fowler's or something like that. It's a little variation thereof, depending on that patient and stuff like that. So planning ahead, thinking about, what kind of drapes do I have that can cover, these kind of areas. I got ones that are kind of in a U shape with sticky to it. I've got, ones that are basically just like a blanket. I've got ones that are have a big hole in the middle. I have ones with, no hole. What can we possibly use here to kind of cover up the areas that we're not going to be working on and show us the sterile area or the prepped area that we need to work on. Lithotomy. This one comes with a few separate drapes. I think you have 4 separate drapes. You have your 2 leggings, your under buttocks drape, and then your top drape. That's going to cover the abdomen and everything up top. So they get put on typically in a specific order. Your book tells you that the under buttocks drape is supposed to go on first. I don't do that because you have to go in between the patient's legs and the stirrups to get that under buttocks drape in. Well, I have a little bit broader shoulders, so it's very difficult for me to get in there and maintain my sterility and get that under buttocks drape in. So typically what I'll do is I'll drape the legs out first. I'll put the leggings on first, and then I'll slide in and put the under buttocks drape in. And it seems to work out too, because then I can tuck the excess of the leggings drapes in with it, and that kind of helps keep them in place too, and they don't keep trying to like slide off and stuff like that. So it happened to just work out. The head drape, I'm going to show you guys this in lab too, but you're going to take a 3/4 sheet or cover sheet and then 2 towels. You'll place that underneath the patient's head, and then with one of those towels, you're going to bring it over and create a turban around the patient's head. It helps contain all the patient's hair if you're going to be doing like a facial procedure or something like that, and keeps the microbes that are within the hair kind of locked up. But like I said, I will show you guys this, especially when we're doing like, you'll see this a lot for ENT procedures. And then lastly, once you bring those parts of the towel in for the turban, you'll clip them all right in the middle here with the towel clip. You just got to be very careful not to get the patient's skin with it. But not only do we drape patients, but sometimes we have to drape the equipment we use as well. More specifically, we use microscopes in surgery. If you're doing, anterior cervical fusions on the neck and the spinal cord or the vertebral column up in the neck, you're using a microscope. You're doing some kind of bone repair in orthopedics or something like that, you're probably going to be using a C-arm. The robot, we have to drape out that robot because we're putting sterile instrumentation and stuff in there. So all that stuff, you learn how to work with all this and how to drape it all. Some of it's a little more awkward than others, but you get through it. It takes time to kind of learn it and become familiar with it, but it also becomes fun. The microscope is probably the most unfair thing to the vertically challenged in the operating room, because and it was even for me. I'm almost 5'9". My nurses, they would set up, because they have to set up the microscope and they have to do what's called a balance of the microscope and run it through all its boot up and stuff like that, and then get it to set up so that when the surgeon is controlling and stuff, as soon as he grabs it and moves it into place, it doesn't kind of like try to drift on him and things like that. Well, my nurses would always take it, and after they did that, they're supposed to grab it and then lower it down so that we can come over and drape it. Well, they would usually leave it up. Well, the arm of that thing is like, like 8-9 feet in the air, and that's another, why they're supposed to lower it. So, I would always have to and throw it up on the thing and be struggling with it and stuff. So for Katie and Taylor and stuff, I would not, Liz and Valeria, the people on the shorter side, I would definitely be on the lookout and having your circulators remember to bring that down for you when you're draping. The C-arm, unfortunately, can't really go down that far, and the robots is everything's going to be kind of in front of you, doing it this way, like in a horizontal pattern rather than a big vertical having to reach up pattern. So when removing the drapes, usually what's going to happen is that the dressings will be on the patient. You'll take one of the towels from your table and leave it still folded. You'll put it down over the top of the drapes with one hand. And with the other hand, you're going to grab the drapes and then pull them over the top of the hand that's holding the dressings. And then the hand that started pulling the drapes is going to now put their hands on the dressings, and then this hand's going to pull the drapes the rest of the way off. And then you ball them up and just throw them in the trash. Easy peasy. And that's prepping and draping. We will go through a lot more of this in the lab. You guys will get to practice doing this. You'll see it. I don't want you guys to go out there and initially when you do go out and externship, they're not going to trust you that, and you'll never drape by yourself until you're like a staff person and you've worked with a doctor plenty of times and they kind of trust you and they know, hey, your aseptic technique, how I like to drape, you go ahead and take care of it, that kind of thing. But that's the rest of chapter 18 and chapter 19. There is no quiz on Monday. The following Monday will be your guys' midterm. We will talk about that in this coming week. You guys enjoy the rest of your weekend, and we will see you guys on Monday.